Okay.
That was awesome. So I'm so excited to have this series co-hosted with Ben. I've been doing, these chats, and welcome everyone. And thank you, PMD Alliance, for continuing to host this. And we continue to be sadly physically distanced, but socially connecting, and we're really globally connecting. It's been really an amazing journey to meet Ben this year and learn from his mind as a young patient living with Parkinson's, a young amazing, honestly, human living with Parkinson's, honestly. So he embodies so many great things. He's a fellow Canadian, and he's just really been an inspiration to me and brought me to so much new knowledge, new interesting people to chat with. And as part of this series, we're going to be exploring Parkinson's from different lenses. And so without further ado, I want to turn it over to Ben to introduce someone that he's picked as one of the first speakers, and somebody who I know is near and dear to his heart. He really, has spoken about her, and I've heard a lot about her from various, mentors, and she's just a game changer. So stay tuned, giddy up. We're going to really be in for a ride. So happy to turn it over to Ben.
Yeah, thank you, Indu. And yeah, we're excited about the slate ahead, but we're very excited about our guest today, Dr. Sarah Lidstone, who's a movement disorder specialist here at the University of Toronto. She also runs the new interdisciplinary clinic that she set up, and I'll give her a second to talk about that soon. But first, to give you a little background, a big part of the reason why I wanted to bring Sarah on, and also something that is related to what I say about Indu as well. So I often talk about them behind their backs to other people. And what I see in this community often is that there's a lot of talk that goes on. There's a lot of people that talk the talk about patient advocacy and involving patients in clinical development and in research and in pushing things forward. But there aren't quite as many people who walk the walk. There aren't quite as many people that actually live that path and that really do what they can to involve patients in their daily work, and more importantly, to learn from patients as well, to learn from the patient experience. And yeah, suffice it to say, Sarah is definitely one of those people. And it's for that reason, and along with a whole host of others, that I'm excited to have her here today to share her story and to kind of get her take on the world of Parkinson's research and what needs to be done going forward. But I guess just to begin with, Sarah, could you walk us through how you got to where you are today? What was kind of like your career path that led you to this unique position you now find yourself in?
Yeah, thank you, Ben and Indu. I'm so delighted to be here. This is kind of like an island of niceness in my week. I feel these are the kinds of webinars I really enjoy participating in, because I have my tea and get to kind of relax and talk with you guys and some like-minded individuals about the kind of work that we're doing. And I always will do anything Ben asks at the drop of a hat. So very happy to be here. I was kind of preparing for this question actually, and I was about to say, well, my career starting my PhD when I was in Vancouver, and actually I'm going to say my career started when I was 11 and I was a patient, and that really, I think, kind of set me up. I remember being 11 years old and wandering through the children's hospital carrying my x-rays in my gown and having a patient kind of view for the first time. That's when I actually I wanted to be a doctor. But then I took a very long path to get there. I started doing research, actually. I began my academic career doing my PhD, and I studied placebo effect in Parkinson's. This is what I did in Vancouver with John Stossel and his group there. And so there I spent 5 years kind of toiling away on the research side of things, but really what that was about was being with patients while they were getting PET scans, which take, an hour and a half each study. And I was doing a protocol where I was trying to show that the words that I told them affected the neurochemicals in their brain. I wanted to show that their expectation of getting better actually released dopamine in different levels, depending on how strongly they believed they were going to get better. And so I did that for 5 years. It took 5 years to do one study. But through that process, spent hours and hours and hours sitting, chatting with patients, chatting with their caregivers, and just learning about them. And then hours in the clinic, getting to know patients and recruiting them for my studies. And all of that was happening without the added, I'm not going to say pressure, but without the added responsibility of being a physician, their treating physician. Because when you're in that mindset, your job is to figure out what's wrong. and how can you treat it, and how can you, you learn all the rules. It's a very kind of black and white process going through medical school. But when none of that is there, you can just relax and get to know people as a human being. And so that's how I started. And I'm not sure if any of you can imagine what it must be like to do a PhD in placebo, where you demonstrate that people get better with a placebo with Parkinson's, and then having to go through all of medical school, learning about all of these other kind of more gold standard type of approaches. You develop I'm not sure even if it's a healthy skepticism, but certainly a skepticism for the kind of medicine that we do. So that's where the seeds were planted. And then kind of fast forward through the rest of my training, I realized if I wanted to change the system, I had to first get myself into a position of relative kind of traditional power where I could do that and have responsibility. And so fortunately, I was recruited in Toronto and given a lot of autonomy to build a program. And so I think, I've been thinking about this, the roots of our program really have started with some of these themes, where it's about exploring relationships, exploring how the doctor and the patient interact, how the whole healthcare and the team interacts, how the environment that we deliver healthcare in actually is therapeutic, and that's real, and that makes sense, and that's not to be minimized, it's to be understood and actually maximized. And so now it's about building a model of care that has all of those things as part of it. So that's a bit of a long-winded answer, but it's the truth. It's the path that I've taken to get here.
That's really amazing. Wow. Thank you for sharing that story. I mean, I think a lot of us start out, with the sense of what being a doctor is going to be like. And for me, I also had some transformation as being a patient as well, and having, some allergic issues and skin issues and stuff, and really not finding help, and really getting into a space where I thought like it was all in my head in some ways, and then, kind of then sort of repairing through some of the mind-body approaches. So I think for me, I think it does come sometimes from not finding all the answers in traditional medicine and having a new lens, new approach. So I think that's really cool that that's where it started, and that you had to sort of sit back and maybe, bite your tongue a little bit in med school when they were telling you all about, how it is from the traditional Western lens. But I think there are becoming more and more of us, Sarah. So kudos to you. One thing, just starting, that you just mentioned the doctor-patient relationship. Ben and Sarah Rigare were talking last week, and I don't know if you saw that video, but they talked about the power dynamic of, a patient coming in and a doctor sort of in this role as sort of the one with the answers, and so could you describe kind of how you think about that and what you've done to maybe alter that? Because it does sound like you've thought about that a little bit.
Yeah, I have. I wasn't able to see the talk last week. I'm planning on watching it, and I apologize for that, because I think I have a lot to learn from Sarah. She's a remarkable woman who I've never met actually, but I have admired from afar, and I've also heard amazing things about. Power is interesting. I think that's a reductionist view. I think there is a difference in skill set that is there. So the skill set that I have as a physician is I have textbook and life experience knowledge about how to put bodily symptoms into context and what I can offer as treatment to possibly help some of those. The skills that I lack are living with Parkinson's. I don't know what that's like. I know I have a better idea because of my work and the fact that I interact with so many patients, but at the end of the day, that's a skill set I don't have. And something actually that I learned through our work in Toronto with our patient advisory board, of which Ben is a big proponent and a big role, is this idea actually of a shared vulnerability, right? So I'm learning in the last year, working with our patient advisory board, about actually redefining this doctor-patient relationship. I have patients who are my patients who I also now work with on our advisory board. And that changes the relationship in ways that I don't want to ignore. I think it's actually really important. And I share different parts of myself with those patients through those different interactions as well. And that's a good thing. I had mentors, I remember mentors in medical school who told me to adopt a single persona with every patient, the one size fits all approach, to actually become somebody different when you're taking on that role. And I really, that never sat right with me. I think medicine is about a lot of vulnerability. I cry in front of patients often, not, when it's appropriate, but I'm not afraid to do that. Because I think, I guess I recognize through my research that the sharing of emotion and exposing of vulnerability in both, that is also healing for patients, I think. Maybe not everybody, maybe some, maybe Ben can comment on that, but the exposure, I think, is what that is fundamentally is connection. And that is a big part of medicine that I think we tend to overlook in the face of diagnostic labs and tests and imaging. It's about human connection, I think, at some level, which has healing potential, far beyond, I think, what we get credit for.
Yeah, I agree completely. And one of my questions actually was gonna be exactly that, which you just kind of just answered, is that life is, whether it's at the cellular level or at the human level, it's all about connections. Nothing can exist in isolation. And something that you do that's also unique is not just bringing the patient voice and listen to the patients, but you also bring in other disciplines into what you do. I think you were very prescient in your realization that the neurologist and the skill sets that the neurologists bring and that the patient bring to those interactions is not enough. You also need the mental health professionals, the physiotherapists, and a variety of others. And I guess, could you talk about just building that team and what it actually takes to care for an individual human being?
Mm-hmm. I can. And in fact, I do have a slide that illustrates this. So if you will indulge me, I will share this one slide. There might be more throughout, but I did prepare kind of a few little things. But this is, so we have what we call an integrated program. That word has, if you actually look it up, it has like 175 definitions when it comes to health, which kind of shows that we don't actually really know how to define it. You can define it, horizontal integration, within a clinic. You can do vertical integration of development health system. What we do is integration at the level of the person, so in the individual. And what do I mean by this? So here's our patient, and I'm a neurologist. I look at this patient, and what I'm seeing is, okay, there's some tremor, there is maybe a gait disorder, there's maybe some mild cognitive impairment, and then a psychiatrist then might say from their lens, their angle, their scope of practice, there's some depression, there's anxiety with panic attacks, there's also a history of trauma that I've unearthed in this interview. And then the patient goes on and sees a social worker at some point. Social worker, okay, struggling at work, social isolation, a small support network, and so forth. And maybe at some point the patient will see a physiotherapist, and they will diagnose a fear of falling, difficulty with transfers, and some bad compensation has developed over time, bad physical habits. So these are all kind of fragments seen through each practitioner's view of the patient. But my question is, okay, so what are the problems that the patient has? And can we flip the model to actually start from there as a starting point? And that's actually what transdisciplinary care is. I'm hoping that I have this, I remember where it was, which is right here, but this is another slide that I had from a paper that kind of shows going across the different models of care in medicine, right? So we have on the far left, the monodisciplinary, what we call the traditional medical model, where we have a patient that is being seen by different physicians, and it's kind of one doctor takes responsibility, sends out referrals, and there can be varying amounts of communication between these individuals, but it's a monodisciplinary medical model. And then after that, everything goes multidisciplinary with increasing amounts of integration. So the traditional carousel style model, where the patient, like I just showed, sees the allied health team members, all in succession, each individually, each offers advice from their own point of view, their own scope of practice. But again, there's no kind of holistic plan that puts it together. You do get that as you go into more of these interdisciplinary kind of care models. But what I'm talking about actually is what's called transdisciplinary care. And so this is actually used in a lot of other industries other than medicine. So it's used a lot in business models that I've been learning about. And this idea is that you get everyone in the same room together that all have different backgrounds and different points of view. And when that happens, there's a shift actually that occurs in how problems are solved, because no longer can you approach the problem from the individual practitioner's perspectives. It has to actually, by definition, come from the patient first. So it flips the model over, and then that problem and how you solve it can then become innovative. So then there's communication around creative ideas about how to solve the problems. And this is how you can design new therapies, new treatments, and you can innovate. It's cheap, it takes time, it can be expensive, but I think that, you know, this is the spirit of what we're trying to do in a more integrated transdisciplinary model. I hope that makes sense with those slides.
Yeah, that was very clear. Really interesting. So then who is in your clinic then? If like, let's say Ben comes in to see you, how, describe sort of a patient visit. How would that work? Where you guys, are you talking about Ben behind his back? Are you talking about him in front of him? Like, how does the patient fit in as well?
So our clinic operates now in a integrated assessment. So all patients that come in get an integrated assessment where in real time they are seen by me, so the neurologist, a psychiatrist, a physiotherapist, and a mental health nurse all at once. And the patient often will bring a care partner with them or a friend or someone with them as well. So these visits cannot have like 4 or 5, 6 people in the room actually. We're doing it all virtually now, of course, but that's the starting point. What we've learned is critical to making those visits go efficiently, because you can imagine it can just generate into like a big mess, is we have the patient fill out a questionnaire up front that actually tries to target what are their top 3 concerns. We start with that. We are pretty focused now on the symptoms that involve movement and emotion. So the intersection of neurology and psychiatry. So that doesn't necessarily apply to things like constipation, maybe some of the autonomic. So it's not that we can treat everything in this model, but really what it's targeting are emotion and movement and how they intersect. So things like freezing of gait, things like fear of falling, tremor. A lot of these body physical symptoms have a very strong, I'm not gonna say like emotional component because often it's not recognized, but the way that our nervous system is designed is where we are at in terms of our emotional state, our autonomic state will strongly influence movement. And if you recognize that, you can then pick apart and find new therapeutic targets to treat them. So it's about recognizing those cycles and those patterns and how do you intervene in the moment and kind of break them down. So the visit is trying to problem solve around these things. We often get people up in the gym, get them moving and watch what happens. We try to provoke symptoms so we can understand why are they happening now, what's going on in the body, what can we do to fix them? And then we design rehab programs around that. So this is all pilot. This is all pilot work. We're doing it in other kinds of movement disorders besides Parkinson's as well with good success. But we're now kind of dipping our toes into the Parkinson's space because we realize that we can probably treat all of these things in a very similar way, actually. And then it's a lot easier. We don't have to design a million different rehab programs, right? We can settle on nailing a few things, but do it really, really well.
So I talk a lot to patients and doctors and other healthcare providers about the PAB and about the transdisciplinary clinic as well. And the question I often get back is, how did you do this? How did you actually get the right people on board behind a project like this? Because in a lot of places they want something like this. I think there's a clear need for this in every center around the world, but actually implementing it and getting the leaders of clinics all around the world to be on board with something like this is a big challenge for a lot of people in a lot of places. And I wonder if you could just talk a little bit about what it took here in Toronto and what you think other centers could learn if they want to implement something similar.
Like for the PAB, you mean?
I think both the PAB and the transdisciplinary clinic are kind of it requires the same kind of shift in mentality to implement.
Yeah, I mean, this is not easy work that comes naturally because people tend to be quite entrenched in the ways that our healthcare systems are structured now. And it is really, I'm not going to underestimate the amount of difficulty that it is to design a new model of care, especially considering cost, right? So we're fortunate to have a philanthropic donation. I think philanthropy plays a huge role in this, especially at the very beginning of designing new things that may not have evidence, right? It's really it's easier to obtain funding for things that are proven to have worked. But when you're in the trenches in a startup kind of model, you've got to raise capital. So funding is really essential, and buy-in at the high levels of the institution. So the vision must align with the overall institution's vision. And we're lucky because right now, everyone's recognizing the impact and importance of mental health in physical health. Mental health is health. It's the same thing, especially with this pandemic. I think it is the best thing about the pandemic, if I can, there are silver linings, but it has shown us about the critical importance of mental health care, and that should be funded in our communities and hospitals. And also the impact on elderly people and keeping people kind of in the home and self-managing, right? So I think there's like the tide is shifting this way. I mean, you guys have done tremendous work in this program, bringing people, like highlighting all the work that's happening in this space. So I think it's trickling up, but the top levels need to have buy-in around this. So I think that's a really, really critical thing. The stakeholders have to buy in. I guess I pushed pretty hard to make a patient advisory board happen, because I recognize that if there is an opportunity you have to build a new program from scratch, why would you not involve patients from day one? Why would you go to the trouble of designing something that you think works in your head and then maybe consulting patients later and you find out it doesn't actually work for them, right? So I'm very collaborative by nature. I'm a collaborative leader. That's how I like to lead, but I was quite motivated to get a patient advisory board off the ground early and involve them in a process. And also I have a bit of a quality improvement background. So I'm very open to the idea of just iterating and changing one little thing and then testing it again, changing and testing it again. You make a misstep, you learn, okay, I learned this, that's super valuable, let's try this time. So having an openness and having your team have an openness to taking these steps slowly over time, but always having a clear idea of where you want to end up. I think these are all the ingredients that it takes to build a successful program. I'm not sure we're successful yet. I can't point to our data yet. Hopefully that'll be in a couple of years, but I hope that answers the question, Ben. It's kind of like the ingredients you need. Yeah.
So much innovation. That's really great. I mean, I think that, one of the things that I think people have resonated in the chat here is the intersection between emotion and movement. And I think you, Sarah, given your background in the imaging stuff that you were doing and spending time and the placebo effect, and I think some of our conversations so far, I mean, we had an hour-long conversation and it like went by like this because we're totally drinking, the same Kool-Aid. And we've kind of gotten to this place after having worked in the space and worked around patients. And I think, as you mentioned, sort of having some knowledge of the basic, treatments, what works, what doesn't work, but then understanding what changes quality of life for patients, and then what are the things that are not understood well, and how can we apply some of these things to really make a difference for patients and what they can do for themselves. I think, because you mentioned, self-management, the mind-body kind of connection space, or emotion, movement. Can you speak a little bit more to that and what you've and I know this could be totally kind of going down a rabbit hole, but I think it's okay. We wanted to have you on to speak about that, and it doesn't have to be, scientifically proven, but wanted to give you a place to sort of speak openly about some of your thoughts in that space.
Yeah, no, it's great. I love the free flowing dialogue. I don't think we have enough of this. We're so used to having to give these very stuffy academic talks, which totally important, have to do it, need to get the message out, but they have a forum for this kind of discourse is also, I think, really, really important. So like, Indu, there's so many different components to that. I think the main message I want to get across, and Hugh would agree with me here, is that I think Parkinson's disease is rehabable. So there's a difference between rehab and wellness, and healthy lifestyle wellness. That's like everyone should be doing that. This is like whether you're Parkinson's disease or anything else. That's a huge component of just a healthy brain, a healthy life applies to everything, and that space is awesome. And you guys are doing amazing work in there. Rehab is like a subsect of that, where it's actually doing pieces of work to target specific problems in a time-limited program and learning skills that will then carry you through, right? So once a skill becomes a learned skill, I would argue that kind of then fits into wellness as well, because you're maintaining a certain level of wellness after that. But there's, imparting skills with people is as important as levodopa. Right. So yes, we absolutely know medication is critically important. We need it. It's a bedrock of treatment, and it lets you do more. But that more piece there are many, many things people can be learning now that I would say falls under rehab probably, that can actually carry people through their journey with their disease. Things like just knowing how to do a proper sit to stand and transfers. We see patients coming to us all of the time who've had Parkinson's for only, let's say, 5-10 years, who already, without them realizing it, have kind of fallen into these bad habits in their body. And so the idea is you teach skills up front. It doesn't matter where people are along the course of the disease. And then there's tune-ups that happen throughout. And having a model of care that supports that kind of transition from active rehab to then self-management, I think is really critical. And in my opinion, should be part and parcel of medical care, period. That's what how clinics should be structured. The rehab should be with the medical care. They should not be separate things. They should be actually occurring together. So that's like where my head is at around that. But it's kind of all part of the same thing, that same space. And it shouldn't be other. It should be part of the gold standard of what we're doing now.
Can you speak a little bit more about that emotion and movement kind of connection though, just as well?
Yeah, so I have more experience with this with the different movement disorder called functional movement disorders, which is defined as a neuropsychiatric condition. But really, if you look at any neurological disease, we can say that it's neuropsychiatric in the sense that all chronic disease of the brain involves mood at some level, and involves anxiety at some level, and involves coping, and involves grief, and involves all of these things. It's actually part of the human experience. And to be honest, most of those things I've just listed are often not pathological in Parkinson's, right? So that's just part of being a normal human being. We have all of these things. So it's about learning how to recognize and self-manage those. But we know, for example, if you see somebody who is depressed, if their mood is low, their movement looks different. They walk slower, their shoulders are hunched over, their voice is softer, they have less facial expression. It comes out in their movement and their body language. That's actually in ways that are very subconscious. If somebody is excited or happy, it's opposite. They're moving more, their face is very expression. They may speak in a louder voice. They might be walking more quickly. Maybe they have a spring in their step. You can tell by looking at people. So that just goes to show on a very basic level, the intersection of emotion and movement. But that's actually because that's how the brain and the nervous system is working. So my thoughts around that, how it applies to Parkinson's, are that if we break down some of the symptoms of movement, we're already landing on more kind of psychiatric or emotional constructs that are there that could possibly become targets. So freezing of gait is a perfect example of that. So freezing of gait is highly, highly tied to anxiety. But the anxiety is actually living in the body, right? So I think psychiatry kind of gets a bit of a bad rap sometimes, but a lot of emotion is actually experienced by the body and not necessarily something that people have a feeling to or can tie a language around it. So anxiety is a very strong physiologic experience. There's tremor that happens with anybody who's anxious, heart rate goes up, people start sweating, they get flushed, right? This is all, they get tension in their neck muscles, everything up here. These are signals that the nervous system is anxious. But if you ask that person, they don't feel worried. They don't feel anxious. That emotional component may not be there, but that still can contribute to symptoms getting worse. And so recognizing that and having strategies to target it, makes you feel a whole lot better anyways, but B, can also affect the motor symptoms of Parkinson's. So I think these are really interesting, cool intersections that are not new. Like, people have known about this for ages. It's just about how you look at it, and then how can you tackle it in a rehab model therapeutically, that I think is really exciting.
Yeah, and to add on to that, something that I've picked up from you and from Hasteel and from a few others that I've spoken to about this is also the concept of awareness, and where your focus and attention is throughout the day. And I see this as having both a positive and a negative role. I think the things you spoke about Parkinson's being rehabable is definitely true. But there is a point at which, and it becomes very difficult. It becomes onerous on the person living through it, to do all the right things in the course of a day, and they can beat themselves up at the end of the day because they know they didn't exercise enough. They know they didn't do everything that they possibly could have throughout that day. But at the same time, you need some level of awareness of what needs to be done and what you can be doing to live as healthy and as good a life as you possibly can. So I'm wondering if you could just speak to that kind of balance that one has to play with oneself throughout not only the course of their rehab, but throughout the course of a day and almost throughout any given moment of the day, as to how much, in your estimation, how much of their attention should be played on trying to rehab the disease and how much should just be trying to live their life?
I think rehab is living your life. I think those are, in fact, living your life is like the best rehab, probably. It doesn't, going to the gym is great, awesome. Go to the gym, get your cardiovascular health, like super important. I'm never going to say don't do that. Go to yoga, obviously, like definitely do those. Walking with your family in the woods with your dog for an hour on a Sunday, even better, right? For your brain, actually, because then there is physical connection, there is emotional support, there is a feeling of satisfaction that you get connecting with others that's better for your brain than just that. So as far as the proportion goes, I think there is no right answer. I think everybody is different. And everyone's Parkinson's is different, and everyone is coming at it from a different place with a different background and affinity for physical activity. Our philosophy, we're doing a rehab program now. We're as you know, we're piloting one, and the whole concept is kind of just move more. Take what you're doing, develop an awareness about how sedentary your day is in general, and just move a little bit more. That's it. And then maybe after that, move a little bit more, right? So we'd much rather see people engaging in that kind of, mental approach rather than I got to go to the gym, do X push-ups, X sit-ups, and do all these because of my Parkinson's. Like there's almost like a punitive or like a punishment in that. The worst thing people can do is I hear in you, Ben, there's like the self-judgment, this little voice like saying you're not working hard enough, you're not doing enough. Like throw that voice out. It's got to go. Everything you are doing is enough because it is hard to have Parkinson's. It is hard to get through the day. Everything you are doing already itself is enough. And then you can start to do a little bit from there. Do you know what I mean? It's a bit of a shift. I don't know. So self-compassion is really important.
Absolutely. I mean, I think the line that you said about living your life is the best rehab. And I think, that's why I think for having that connection, being able to talk about what defines quality of life for somebody. It might be playing with their grandkids, somebody it might be, just being able to, enjoy walking their dog, in their garden, and that's something that they really look forward to. So I think, everyone's very, very different. And so I think, getting back to what brings purpose, what brings meaning, what brings joy, I think understanding that is going to be different for everyone. And then, figuring out bite-sized ways to incorporate this. I don't think neither Sarah nor I, who spend a lot of time, I think, in this space being cheerleaders, want to like ram like 50,000 things to do on your calendar and then stress people out to the point where they don't have any fun. And I have patients who literally before the pandemic were driving across the city to the best mindfulness class and then stressing out about getting to the yoga class in traffic. And I'm like, what are you doing? Like, we're stressing you out so much to get to your self-care that maybe something's wrong with this sort of self-care, right? So I was telling people to take some stuff off their calendar, sleep in a bit and, just relax a bit, enjoy yourself. I think it's a balance, right? We have to kind of think about the things that we know are beneficial, but I think having reasonable goals and then really what brings you happiness. Ultimately, we want you to live a life that is full of joy, something you look forward to, something you love to engage in, and with the people that you love. I mean, that's really what it's about, not to take time away from the people that you love, spend $1 bazillion, in a gym and isolate yourself. That's not, and hate it all the while. That's still definitely not success for us. And we also have to think in these conversations when we're talking about rehab and wellness, what's accessible to many of our patients. They don't have, resources. We need to find ways to make this not shame people into feeling bad that they can't afford, the best food choices. They can't afford the gym membership. They can't afford all of these, things. So I think we just have to really take a step back and say, what are some simple life pleasure sort of things that can be easily incorporated to make things better? But so much good stuff there, Sarah, for sure. I think, it would be helpful to understand also, so you talked about the rehab piece. Are people in your clinics and first of all, are you doing this integrated model from diagnosis, or when do you think this integrated model should start?
Well, I guess you're probably gonna know what I'm gonna say. Like, I think it should be from the very beginning, obviously. I think it should be from day one. I think all of our clinics should be structured differently to incorporate some of these ideas. I think the rehab should start from day one, and looks different though for everyone kind of over time. That's the nature of what happens living with a chronic illness for many years. We are, as I said, we're starting small. It's a pilot at this point, but what we're hoping is that by seeing enough people through this lens, that common denominators will start to kind of precipitate out, and then we can develop more structured programs around some of those. And one of them we're trying now, which I mentioned, is this kind of virtual rehab program that we're doing, which has been a really interesting way to approach treatment of Parkinson's, because we're looking at kind of mind, body at every step. So physical health, mental health, connecting with people, all sorts of planning for the future, all sorts of different things kind of wrapped up into that. It's very skill-based. So I think skill-based approaches to care are really the way of the future. They're so complementary to the medical model. It's just getting them out there. And I think they can be delivered in a much cheaper way than a lot of other medicine is, because that can be done by mental health nurses, by various different types of therapists that aren't a lower pay grade than physicians, if you know what I mean.
Mm-hmm.
Yeah, and as you said, I think we have a lot to learn from this community and from each other and from all of our interactions together. And one thing I wonder about is, and this is, I guess, for both Indu and Sarah, is in your dealings with patients and you've seen what works and what doesn't for different people, how much of that do you apply to your own life? Because as you both know, I mean, you're both to some degree anyways at risk of getting this disease yourselves one day. Is this something that you ever think about? And what lessons do you learn from your patients that you apply to your daily living?
Did you want to start with that one, Indu?
You go, Sarah.
Oh, that's a tough question, Ben. You know, I'm probably not a good example always of practicing what I preach. I would have to say, I do struggle with balance for sure. It seems like I could never attain it. I'm kind of in the throes of work at the moment, but it's really helpful to work with a psychiatrist. I will tell you, I feel so lucky, because it's like having therapy all the time, sharing with patients. But you know, what I've learned through that work is really a constant challenging of not being so hard on myself. That's definitely a big part of it. A lot more kind of self-compassion, as I mentioned earlier, and this whole kind of concept of checking in and understanding where I'm at. I don't think too much about developing Parkinson's one day. I have not. I certainly don't worry about it on a regular basis. I have other health concerns that I'm far more worried about getting worse over time. Like I mentioned earlier, I might have to have a pretty significant surgery coming up. So I have kind of things that could trump that for now. I've not tended to be, though, I'm kind of a throw my bag over the fence, got to go after it kind of person. So I would say I don't have anxiety around the future very, very much about that. I'm not sure if that helps at all, but that's my own personal.
Yeah. And for me, I think I definitely have, felt the benefits of some of these approaches. I do kind of try to live my life around the things that I try to talk about. So family is huge, social connection is huge, and has been, for a long time. I think, sort of taking time to reflect as well, checking in, like Sarah said, about your body and sort of learning about the mind-body kind of connection. And, oh, like I'm feeling my heart rate's up, like what's going on? Like, why am I, did I not eat? Did I not, hydrate, keeping all that stuff, sleeping more, a lot of the stuff that we kind of were taught in medical school to not do, sort of like sleep when you're dead, like work. And, I don't think I learned anything about exercise, sleep, any of this wellness stuff in medical. I went to the University of Toronto, which is a great medical school many years ago, but I think these models are changing. So I think, as I'm living my life, I'm trying to practice what I preach, but I also think that for me, outside of the pandemic, and I've been really focused on, some of this area recently, but I really enjoy the beauty of life. So I travel a lot, love to eat great food, love to listen to beautiful music. I enjoy the beauty of the world and have really not put things off. Like, so if I'm like, oh, I'd really like to try to do that, I find ways to sort of incorporate those pleasures throughout my day, throughout my years, and don't want to keep it all for someday. So, because I think that that's what's Parkinson's has shown me, being around patients has shown me, is that, things can change. So it's important to just, do what you can and think positively and sort of try to spread some happiness and joy while you're at it. So that's sort of, I guess, how I'm living my life. But Ben, these are good questions. Wow, I didn't know that you're going to start like.
Well, Indu's a much better example of that than I am. I mean, I just did yoga like for 10 minutes before this because I felt like I had to cram it in before I was meeting with Indu.
Good. Good. And we have to take care of each other too. I think one thing that I've realized is, I think the sort of power struggles or whatever we're taught about the doctor, patient, researcher. I really, before I think I went to medical school and before I took care of so many patients, thought we had a lot more answers. And I think we have a lot of questions that are still unanswered, and we can work together with our patients to sort of, I think, dig our way through some of the stuff. And I think we have to keep an open mind and keep listening. The dialogue's important. And I think that's been something that this has shown me, is that we can globally connect in pretty amazing ways, just, with technology. And there are many more of us, Sarah and I, and we're trying to collaborate and include patient voices on some of this stuff. But I think, like you said, mental health is hugely undervalued. And I think the spotlight's a little bit more on that now, given COVID and the wellness stuff and, social connection and all these things. And I think thinking outside the box with these remodels are also really key to, I think, sort of just the white coat doctor sitting in an office, and the sort of 30-minute twice a year kind of interaction is probably not nearly enough. So I'd like to get into a little bit more about, sort of, you talked about the multidisciplinary team and also the team members maybe in the community, the sort of people that don't need to be paid, at a physician salary that we can engage. Have you thought about, and I know Ben's been thinking a little bit about some of these other models as well. Maybe we could dig a little bit into, if in the perfect healthcare model, Sarah, if we gave you $1 bazillion or not even, right? Not that much money, and you were in charge, what would you sort of think about realigning this model to include?
I think the vision I would have if I had resources like that would be that every patient in the world with Parkinson's can get excellent care either at home or within 10 kilometers from where they live. And they wouldn't have to go to an academic center to be able to rely on having kind of expert care. What that needs is a very robust community network of trained providers who can deliver rehab to help with Parkinson's, or who have knowledge and information combined with community, right? So it's essentially a network-based model, similar to what they're already doing over in the Netherlands. They have a good model there around physical therapy, occupational therapy. They have the whole country literally networked so that any patient can type in their postal code. All the trained providers come up who are in their network. They can look up their bios and they can go and see a provider who knows how to deal with Parkinson's. So I think it's about having a very, very strong community outreach network. That's also cost effective. That, I'm really sitting back in the gym now and I'm watching when our mental health nurse and our physio are paired together working with a patient. It's the best. It is like sparks are flying. It is super cool. The patients love it. They're like discovering new things. They're surprising themselves because that blend in perspectives is really amazing. So I think that's a really interesting model that also could be more financially sustainable as well. And probably like a backbone of kind of like a curriculum, like knowledge and education are power, and really empowering people with these self-management strategies within their own communities, I think is really critical. And that can look differently in every different community, and it has to at some level, I think, be that way. It has to be different everywhere, but there has to be a minimum quality common denominator that goes across the board, where there is a maintenance of good quality knowledge within the network as well. That's my vision.
I hope it gets realized. One aspect of this that we've touched on, and I'd like to just delve into a little bit deeper, is the mind-body connection. And in particular, if you've seen any particular traits in the patients that do particularly well, that are able to maintain their mental health throughout the course of their disease, that you think are valuable lessons that the community can learn from.
Mm.
And I mean, and also just trying to put it in very practical terms. If you think about like your hands, for instance, and if you start to lose ability in your hands, if you start to lose dexterity, if you start to lose the ability to do the things that, like buttoning up a button, becomes a challenge for a lot of people along the way. Like all these little things, all these little traits, it can be very difficult and very challenging to not associate that with yourself, and to actually know that even though this is happening in my fingers, this isn't necessarily a deficit to me as a person. It's just kind of something that's happening in my fingers. So I guess, yeah, could you talk about, from the experiences that you've gathered and from the wealth of knowledge that you've both accrued, about what it takes to actually develop that healthy mind-body connection and relationship, really?
And that's a huge question, Ben. I mean, I'd be very curious to hear Indu's thoughts as well. I think, you know, there are patterns, of course, that we see clinically. I think the patients in my practice who tend to weather Parkinson's a bit better than some others might are quite resilient. They often have a very good sense of humor. Sense of humor is pretty important, I think, in just a general perspective on life, and optimism, I think, is helpful. They tend to generally be more active, and I would say probably have either less anxiety or have anxiety that's well managed and well treated. Anxiety can really destroy and amplify body symptoms, and it can wreak havoc in people's minds and bodies. And I think it's also treatable, right? So that's something really important, I think to say. You know, it's very easy to fall into these loops of kind of self-blame, where you notice there's a deficit in the body, and that itself can cause anxiety, and then there's kind of the spiral that can happen. So parts of these spiraling, I think, are what we can target with these kinds of therapies I'm talking about, but also can be targeted with things like cognitive behavioral therapy or CBT, meditation, mindfulness. You know, it also brings me back to, I was thinking about this earlier in the conversation about, you know, life being therapy, and people feeling bad about not doing the right kinds of treatment, right? So we had a rehab program happen last week, and we had a patient who was saying, you know, I was getting super stressed because I tried to do the mindfulness and I hated it. I tried to do the yoga and I hated it, and I couldn't do this, and I couldn't breathe. But she's a photographer, and she's like, I take my camera, I go in the woods, and an hour later, I feel so much better, and my symptoms are so much better. So for her therapy is wildlife photography, right? So that's better than any mindfulness session that she could sit through. So I think just maintaining engagement in the activities that you enjoy is really, really, really critical to approaching this condition, and also an openness to transformation. Right? Things are not going to be the way that they are all of the time. They're never going to stay the same as they are in this current moment. Things are always going to be changing. That is something I've learned from patients with Parkinson's, for sure, if I think about it. Openness to the idea of transformation is really critical to accepting and living with kind of anything that happens in your life that you wish wasn't there. So that's my own thoughts on that one. I'm not sure what Indu has to say.
Yeah. I mean, I think, yeah, we've been talking about the secret sauce, right? Like, so what defines that? What I think the word resilience has come up, you know, the sort of sense that, you know, people have a positive attitude. I think when you can give back to other people, if there's sort of this connection, you know, people who get inspired to a place and then actually start advocating and activism, and there's this energetic sort of shift of, you know, sort of the negative sort of concepts of grief that you mentioned with the diagnosis. But then I think there's a pivot and sort of this transformation, I guess is a good word, where people, and you see it in these, you know, your patients, as you sort of give as a provider and as a cheerleader, you sort of are like, you know, I have this news, you know, you have Parkinson's, and these are the things you can do. And people start to sort of accept, and there's these stages, but then at some point, sometimes there's this shift, and it's kind of magical. And then you see this sort of energetic sort of, and people sometimes then are living in a better way and a better mental framework, and sometimes get healthier and well, or more well than they ever were before, because of a transformation and a change. And I think a lot of it maybe has to do with attitude, sort of purpose again redefined. These are so hard to, and I think we're still trying to learn this, but I thank you so much for that question, because I do think that is something that we need to identify. And Sarah, you and I will try to spend a little bit more time sort of learning from patients and trying to put this in words and teach our other colleagues. We have about 5 minutes left. I know Hugh's been asking all kinds of questions about now. He's using the word now, so something about now. And I think what can patients do now? So what maybe we can use that. And Ben, I want to just also give you a chance to sort of give your last sort of questions to Sarah as well, but I want to be mindful of time.
So Hugh, you're asking, what can we do now? Well, first of all, I would say everyone is starting from a very different place. So the now is for everyone's going to be very different. I would say there's a lot that goes on this list, but what I wrote down to start with are learning about recharging and learning about moving more. So these are kind of the two fundamental tenets in our rehab program. So what I mean by recharging is the concept that there are things that drain all of our energy. It will look in different forms. It can be things like anxiety, things like depression type symptoms. It can be an annoying neighbor. It can be a demanding child. It can be caregiving for parents. There's all sorts of different things that deplete our battery. What's essential is to develop the skill of, at any given time, knowing where your battery is and knowing what it is that fills your battery, and having that be a practice that is daily, weekly, whatever makes sense to you, and being quite regimented about it. Actually, it's really critical for it's a way you can kind of package and look at self-care that doesn't really have to distill it down into like a diagnosis, right? It's about your own energy and your balance there. And the second thing is moving more. So one thing that we did is we got people to just track in a given week what their activities are, no judgment, just, write it down on a little calendar if you want, and just take a look at, in any given day, how much of a day are you spending sitting down? And start from that and just try to switch a few of those into getting up and moving, whether it's getting up and literally doing 3 sit to stands, or if it's going up the stairs more, if it's parking farther away. These are small things, but it causes a shift. So I would say those are the 2 things. And they also combat low motivation and apathy, which is something we're all struggling with, especially right now. And also really feed into the ability to preserve the connections that you have. So it's who are the people in your life and strengthening those. So I guess that's probably a third thing I would say is the quality of relationships in your life. So I think those are the 3 things. So moving more, recharging, and investing in the quality of your relationships, I would say. For anybody, whether you're Parkinson's or not. Like, I have to do all of these things. Probably more than I am. So
yeah, that's amazing. Ben, do you have a last question or something for Sarah?
Not really a last question, but more of a last comment again for both of you. Just to say thank you. I think that we in the patient community need more neurologists like yourself. I think you mentioned, Sarah, that everyone in the community, you wish everyone in the community had access to the right care networks and the right facilities, but I wish, and I think the critical part of that is having access to people that listen to them and that really engage with them on a personal level as well. I think having that relationship with your patients, having doctors that are willing to go the extra mile for people that they care for, I think that is what is needed more than anything else right now. And so, yeah, I just wanted to say thank you for all that you do and for really embodying what I think a neurologist should be.
Thank you for inspiring us, Ben. People, I think both of us take a lot of, I think we are blessed to take care of patients. And I know that, Sarah, it comes from the bottom of your heart, really. It's sort of your life passion, I think, and I feel the same way. Sarah, before we let you go, maybe the last 2 minutes, so you talked about recharging your battery and what is that thing? Maybe give us a couple of examples, just maybe practical examples. And it looks like somebody's ready to move to Toronto, by the way. To come to you.
Well, if you're in California, I'd rather move to California. California right now, but
Come on down, we'll all get together.
I'm coming to LA. I really miss traveling. Yeah, so I think, you know, ideally the things that recharge, like if you can kill 3 birds with 1 stone, that's the best. So if it's something that can engage your body in some movement and in some kind of social connection together, that's really a great place to start. So walks with friends, walks with family, doing a dance class, you know, if you're doing a yoga class, anything like that that kind of moves the body as well, I think then you're getting rid of 2 of those things. Some people recharge best on their own, and that's also great. So even just reading a quiet book for 30 minutes can be recharging. Having a bath, just, you know, sitting and looking out the window, right? But if it's done with intention, and the purpose is, okay, you know what, I'm starting to feel that I'm depleted. I'm struggling, I'm getting irritable, I'm snapping at people, or I feel very fatigued, my energy is low. Okay, that's a sign. Your body's telling you a sign. Recognize it, listen to it, and then engage in one of these things. But there's a whole list in our newsletter. We have a whole page that's a list of all these different things. We can try to share it with you guys. I'd love to do that.
Yeah, I love your newsletter. I think it's a beautiful gift.
Yeah.
Yeah. So we'll definitely link that. This hour literally flew by. I'm so excited for continuing the dialogue though. And we will, you know, try to work together and collaborate with our Canucks up there. And I'm just excited that, you know, Toronto movement disorders, from being a medical student, was, you know, very in the box, very, you know, this is how it's going to be. And I, you know, was very blessed to learn from a master, you know, Tony Lang, and just, you know, but you've really, it sounds like so much amazing stuff going on. So proud of how it's grown and how you're engaging the patient community, and love the advocacy from both of you. And we will continue to have movers and shakers as we move forward, and look forward to where Ben, who's going to be the next special guest, and get on that ride around the globe to bring a lot of, you know, out of the box discussion. So yes, we'll definitely link the newsletter and any other resources that we can share here. And somebody also wanted to see if they could get the questionnaire that you also sort of share, ask patients when they come to your clinic, if that would be something you would be willing to share. So yeah, thanks so much. I will hand it back to you, Andrea, for our goodbye wave, but thank you both so much. And, you know, love the social connection just with both of you.
Thank you, Indu and Ben, and thanks everybody for having me. It's wonderful to be here.
Thank you. And I invite everyone to turn on their camera if it's been off, and Sarah, Ben, Indu, scroll through and just see all the smiling faces of folks grateful for the work that you're doing and sharing it with us today. Thank you, everyone. Thank you for your amazing questions, and thank you to all our guests.